dear colleagues, dear friends, it's a great pleasure for me and also a great honor to welcome you all to the second St. Gallen EORTC Gastrointestinal Cancer Conference. You've come from far away, from all over Europe. So on this map, I've signposted from which European countries participants have registered, but not also all across Europe, also all across the world. Now, some of you might wonder why we hold an international conference in a small town in some remote part of eastern Switzerland. Now, actually, St. Gallen has had for a long time very good international connections. Actually, St. Gallen was founded by people who came from far away. It was actually in the year 600 when priests from Ireland started to travel towards Italy, and they stopped in France and were joined there by a French priest. And at that time, France was also known as Gallia, so they called him Gallus, the Frenchman. So their next stop was at the Lake of Constance, which is quite close by, about 5 kilometers from St. Gallen. And they started to Christianize the native people in all those little villages all along the lake shore. After a few years, they decided to travel on towards Italy, and Gallus, or Saint Gallus as he is known today, decided to stay behind, and he settled in the hills above Lake Constance, about at the spot where today's St. Gallen Cathedral is located. At that time, it was primeval forest in this area, so he was quite alone. He had quite a long life, and when he died, his followers decided to build a monastery. The monastery started to grow and grow, and after a few years, a city started to develop around the monastery, and today's outline of the inner city still shows the old structure of this medieval settlement. In the 1600s, St. Gallen became the center of the local linen trade. And linen was exported from St. Gallen all over Europe at that time. So the St. Gallen merchants made contacts in different European countries to sell their linen. And they brought back influences and impressions from all those countries. Later on, they with fabrics from St. Gallen, they traveled to other countries across the world. And those impressions you can still see in St. Gallen. If you walk through the old city center, you see all these oriels. They used to decorate their houses. And on these oriels, you find carvings of that refer to this worldwide trade with continents and exotic cultures, exotic fruits, exotic animals. So take a walk through the city center and have a look for yourself. Then later on, in the middle of the 19th century, cotton started to become important. So the linen industry in St. Gallen went down, but instead they started to make embroideries. This is an example of a typical St. Gallen embroidery. that was exhibited at the World Expo in Philadelphia in 1876. But even today, St. Gallen embroidery is sold all over the world, and if you have a big party, you might want to wear some St. Gallen embroidery. For example, if your husband has a new job, here you can see Michelle Obama wearing St. Gallen embroideries. Now, I hope I've convinced you that St. Gallen has some international connections, and I just hope you'll have a very, very interesting 3 days with us here at the St. Gallen conference. And now I'd like to ask my dear co-chair and friend, Manfred Lutz, to say a few words on how the conference will be structured. Thank you very much.
Yes, thank you, Florian, for the introduction. We are here not really because of the embroidery, I guess, or the monk who was a famous one, but we are here because the St. Gallen Conference series has been initiated by Hans-Jörg Senn quite years ago and is well known as a good forum for the treatment of breast cancer, primary treatment of breast cancer, that's curable breast cancer, adjuvant, neoadjuvant therapy. And as a past chair of EORTC, I was very happy when I was approached by Florian and indirectly by Hans-Jörg Senn and asked if we shouldn't kind of expand the breast experience to the GI field and initiate a series of conferences every second year where we in-depth treat issues on specific GI cancers and then have a panel session where we discuss where open issues are and if there may be interesting studies to perform. And the look back is the first conferences started 2 years ago. It was a big success. We had people also from all over the world. And the topic then was early esophageal and gastric cancer. It was well published afterwards in a book. You will get that this time also. And we had from the Saturday session a manuscript in the European Journal of Cancer. And also this time I can tell you whatever we discuss on Saturday, we will summarize that and get the interesting topics together in a manuscript within, and that's the strength also of the St. Gallen Conference, within 2 months or something like that. That's the promise. This year we changed topic. It's not upper GI cancer, but just the other end. We thought that it might be interesting to see where open issues are in rectal cancer. There are many guidelines, you know that, and from reading through the guidelines, German guidelines, European guidelines, ASCO guidelines, there are many things clear, but there are others which are much less clear, and that's why we decided to focus on this topic and go in depth into a few issues, which we would then also discuss with you on Saturday. So we have 2 days of meetings, conference, presentations, and then we will try to extract for Saturday a few topics which are of interest and not well covered in the guidelines. And I just put out a few things which will be covered by questions and expert discussions. And one is the question, how do we best stage? What's a positive lymph node, for example? What do we do with a positive lymph node if it's 2 centimeters or only 5 millimeters? Is that a difference for the approach? If we have cancer which seems easily resectable by a good surgeon, do we even need chemo-rad? That's something which is, I think, not well solved. Or also, if the tumor is completely responding to therapy, do we still need surgery or can we just leave it there? Do we need to skip in some patients chemo-rad because the risk of systemic metastasis is much higher, so they would much more profit from chemotherapy as we do it in colon cancer. And the second topic, to expand that a little bit, is what do we do if a patient has a rectal cancer and also synchronous development metastasis? I think it's easy. If you can take out the primary, then you kind of look a little bit what's first and operate both. But what happens if you have to leave both in because the patient is too old you need to find different solutions. So these are issues which we would like to discuss with you on Saturday. So I encourage you to stay through the conference and then listen what the experts will vote and discuss on Saturday. So that's what I would like to kind of say to the conference, how we set up the whole meeting. And for today, I have a small adjustment to announce, or actually it's a big adjustment. The keynote lecture will have to be skipped today. Klaus Pantl, unfortunately, got sick and called in yesterday that he cannot come. So we wish him the best from here, but that leaves us, on the other hand, a little bit more time for the 2 sessions we have in front of us, which is something like 10 minutes or 15 more for each session. So I think we should try to end the morning at 12:30 as planned, and that's why we started 10 minutes late this morning, so that we have a little bit more time to discuss with you. And as a next speaker, I would like to introduce the current chairman of the EORTC GI group, who is Arnaud Roth from Switzerland. He will present a very important strategic project of the EORTC GI group, where we think that we might be able to kind of develop a way of treating patients individually in the future by the means of a patient database, which he will present us in the next few minutes. Arnaud, please.
Thank you very much, Manfred. Good morning, everybody. It's a pleasure to be here, and thank you for the invitation, and to all the organizers. So, yes, I would like to present you one of the projects of the group. I would say it's the one who took a lot of energy over the last few years. I wouldn't say it's the most important, because there are other very important projects in the group, but it's important because it's a new concept, and actually it has started. We are not speaking about future project, but a present project. So, SPECTAcolor, it's a screening platform of the EORTC for clinical trial in advanced colorectal cancer. So, you know, I mean, the biology is very complex, and of course there are a lot of publications trying to understand the mechanism of biology, and of course we accumulate a lot of data. But you see, it's not useful if we don't ask the following question, but what can we do with them to help our patients? I would like just to remind you about 2 definitions. About markers, you have 2 kinds of markers, the prognostic and the predictive markers. Prognostic means potential to predict the survival. What is disease-free survival, overall survival, whatever. And the predictive marker has the potential to predict response to a given therapy. Of course, a lot of markers have the double potential, like the estrogen receptor. I mean, breast tumor with a positive for ER positive have better prognosis and also are more likely to respond to hormonotherapy. But I mean, some marker can be one or the other, and that has to be really kept in mind. So, what are the major problems in the management of colorectal cancer, or of cancer altogether? I mean, among the problems, there is a shortage of better prognostic indicators than TNM to decide if we need to give adjuvant therapy or not. So that means that for people who anyway are cured by surgery alone, you give chemotherapy for nothing, and also it's a financial waste. But that's not the subject of today, but it's the second problem mentioned here. It's shortage of drugs and shortage of response predictor for treatment. That means that at the moment we don't have any predictor like in antibiotherapy. We have each patient is its own test tube. And also there is a lack of tool to select the good treatment for the good patient. And so, of course, it would be great if we could have markers which could tell us, yes, this drug has the highest likelihood to be efficient in a given patient. Actually, we have already one predictive molecular marker, and I shall show you an example for colorectal cancer. It's a tool to avoid unnecessary toxicity, as mentioned before. And here you know the EGFR signaling pathway where KRAS can be mutated. And you know in B that when it's hyperactivated, you can give an antibody. Here it's a cetuximab, but it could be also the panitumumab, and you can block the pathway. But if the KRAS is mutated, it is like the accelerator in your Toyota when it's blocked down. It push, even if you block the receptor. So it's not efficient. So we know that we have to look at KRAS and even NRAS now and make sure that it's not there is no mutation before giving one anti-EGFR therapy. And you all know this study comparing panitumumab versus best supportive care. On the left side, you see that patients treated even with panitumumab who are mutant didn't respond. That's a forest plot showing that there is no response, while on the right, in the wild type population, you see clearly that a good third, even not far from a half of the patient, had some response to the treatment compared with the control where there is no response. So the problem is that NRAS, KRAS is a negative predictive marker because it tells you who shall not respond and not who shall respond. And this is because, you see, only 45% about of the KRAS, NRAS wild-type patient respond because there are some other actors in the response and where they are mutated, and some are known, some are suspected, but probably the non-responder wild-type have other problems which preclude any response. But the predictive molecular marker can be also a tool to maximize targeted drug efficacy and to accelerate drug development. And it's actually the principal goal of SPECTAcolor. I give you an example. You all saw, I think it's 2 or 3 years ago now, the publication about crizotinib in the New England Journal of Medicine. Crizotinib is a TKI which blocked the ALK translocation, which is present in 2 to 7% of the non-small cell lung cancer. And it's a very specific inhibitor of the transmission of this translocation, and it's very active. And actually, it's truly active. You can see that in second line, they obtain in the selected population, patient population, 57% of response, which is unheard of for non-small cell lung cancer. But the downside of that is, look above, they had to screen 1,500 patients to select 82 patients who were had the translocation and who were entered into the trial. So it's a major effort, and of course it would have been great if there were parallel trials benefiting from similar testing available at the same time for all the other patients. Because, of course, it's a waste. 1,450 patients, more or less, were simply left alone, and we didn't do anything with them. Maybe some went into another trial, but most of them carried on without any research care, I would say. So actually, the classical way to conduct a trial and screening is to try, like in the crizotinib trial, to screen with one reference lab, and if the patient doesn't fit into a trial, to do some others. And so each time you have to get a consent form, to send a new piece of material, and to wait for the answer of the lab, and so on and so on. It would have been much better if we had one major screening which become available to all kind of trial, so the patient would sign one consent form, then there would be a general screening, and of course the material would be available for any kind of additional screening requested by any kind of trial. And this is actually the real advantage of this platform. The patient at the sign, so he agrees that the material goes to a centralized bank. There is a first screening, general, with source and marker, which can be evolved with time. And then, if ever a trial is available for him, I mean, we can rescreen for specific marker and see if the patient can enter a specific trial. And here you can see one patient can get into a first-line trial. Maybe it will not be eligible for a first-line, but a second-line trial later, or even a third-line trial later on, depending on his the specific features of his tumor. But at least everything is centralized, and if he fails to be enrolled in one trial, what we have, the information we have from the screening of his tumor is available for the further testing. It's not in the drawer of a pharma, some secured and of no use. So the EORTC screening platform network allows patients to be screened at once for potential inclusion in several clinical protocols. It allows to allocate the best drug to the best patient, according to what we know today. It allows to reduce cost. Of course, we can already, when a company come to us and say, we need KRAS mutated, second line, and so on, we can say, okay, you have just to screen this patient population, don't take care of the other because they are in first line or they are not mutated and so on. So it's a lot of cost reduction. It allows also secondary cross-trial investigation on the material, of course, and a lot of research with this. So this is in gross the whole concept. I mean, there is it's a big network which has to be done because, of course, we first have to get the material, then the patient is followed on a 6-month basis. We have the information, very simple information, if, of course, the patient is still alive, what line of therapy is on, and what is his current status. So then when we have a trial which could be of interest for him, we can indicate to the investigator that there is this opportunity. The other advantage for the patient is once the first screening is performed, the screening is transmitted to his physician. So the physician has also the information about the screening, and if ever a drug could be of interest for him later on, even outside of a clinical trial, I mean, for free, he can at least, he has a screening and it can be used for his own treatment. So what do we need to conduct this consortium? An active, dedicated clinician network, of course. We need also an efficient pathology lab network, and we are in collaboration with the European Society of Pathology, the ESP. We need a central center to coordinate this thing, and that's at the EORTC. We need partnership with the industry, and this is already starting. And we need also some support, because to start this thing, it costs money, and fortunately we have Alliance Boots, partnership with a fundraising organization. And as you can see, since 2011, they did a lot of work to raise money with major events, and even the former president of EORTC, and here the secretary and the chairman of the group participated to some jog and semi-marathon, so to raise money. Here, at the same time, this is the network, all the infrastructure the EORTC built up. For registration, everything is electronically controlled. So, because it's a big infrastructure you need to have this kind of project running. And actually, it's a big effort, but we make it happen. The project design started in 2009, 2010. Fundraising activities started in 2011. The submission to ethical committee started at the end of 2012, and the consortium agreement was signed by the first 14 institutions mid of 2013. The first patient was enrolled mid-October, and I'm glad to say that we have more than 120 patients now in the system, and of course we are starting new institution. So we truly think that by the end of the year, first year, we have more than 500 patients registered in this network. So truly, you see, collaboration is fun, and I thank you for your attention.